Hello everyone and welcome back to Ultrasound teaching videos with Dr. Arshad Nadeemawan. Hope you are all okay, you are all enjoying your life, you are all enjoying watching my videos and also enjoying practicing ultrasonography. Today my topic of discussion is pancreatic neoplasm. In other words, you can call it pancreatic cancer. Before going to discuss about the pancreatic neoplasm, it is important to discuss one of the anatomical area which is called as periampullary region. Periampullary region is consists of three anatomical areas: common bile duct, pancreatic duct, and ampulla of Vater. These three are considered as a periampullary region. And the tumor, malignancy, and neoplasm of these areas are difficult to differentiate from one another, and they are managed identically by pancreatoduodenectomy, which is called as Whipple resection. And jaundice is the common presentation of all these tumors. Tumor in this group include pancreatic ductal adenocarcinoma. It is the common one. It is on the top list and 85% accounts for the malignancy. Second one is ampullary carcinoma. It accounts 35%. Duodenal carcinoma, it accounts 15%, and distal cholangiocarcinoma accounts 10%. These are four malignant tumors which occupies periampullary region, and these are very common, and Whipple operation and Whipple procedure is performed for the resection of these four malignancies. So far survival rate is concerned, survival rate is best for the ampullary carcinoma and the duodenal carcinoma. But for the cholangiocarcinoma and pancreatic cancer, survival rate is very poor. Ultrasonography is one of the best and initial investigation for those who presented with obstructive jaundice. Pancreatic ductal adenocarcinoma is one of the most common primary malignancy of the pancreas, and it contributes 85 to 95% of all pancreatic malignancies. Pancreatic ductal adenocarcinoma has slightly male predominance and usually seen in 60 to 80 years of life. So far, the contributing factors are concerned. On the top list, there is tobacco. Those who are smoker and especially chain smoker, they are at high risk for getting the ductal adenocarcinoma. Obesity is another risk factor. So far, chronic pancreatitis and autoimmune pancreatitis is concerned. These both can lead towards the pancreatic ductal adenocarcinoma, while diabetes and cirrhotic, these two are also at risk for the pancreatic ductal adenocarcinoma. Those patients who have already pancreatic cancer in their families, they are also at high risk. For the pancreatic cancer imaging, there are two criteria. The one is resectability criteria for the pancreatic cancer. The another is unresectability criteria for the pancreatic cancer. So far, the unresectability cure is concerned. Mainly, pancreatic cancer imaging has three main concepts. The one is, like, the vast majority cases are unresectable. So we should know that what are the categories, what are the landmark where the pancreatic cancer cannot be resectable for the cure. And the second thing is, one should have in this mind that only 10% of tumors are resectable at diagnosis, with an overall 5 years survival rate of only 2 to 3%. So I have mentioned the unresectability criteria on the CT scan and Doppler imaging, and beside this I have also discussed the resectability criteria on these imaging. For the detection of the pancreatic cancer, CT scan and ultrasound both can be used. When patient present with obstructive jaundice, so initial method and initial modality would be ultrasound. On the ultrasound, we can pick the pancreatic cancer. It depends upon the operator practical approach and operator experience. So for the CT is concerned, actually it's not operator dependent, so therefore we usually prefer CT scan to detect the tumor. MRI, MRCP, ERCP, and endoscopic ultrasounds are reserved for the complicated cases. Pancreatic ductal adenocarcinoma is usually seen in the head region. 80% it involves the head region. In 30% cases, you will see the tumor within the body and tail part. On the ultrasonography, you will see double duct dilatation sign. It means that pancreatic duct would be dilated and CBD would be dilated. These two are the signs can be seen on the ultrasonography. So far, pancreatic ductal adenocarcinoma is concerned, it has desmoplastic reaction. If the tumor is eccentric, if the tumor is slightly away, but you will see it will cause ductal dilatation, so the duct would be dilated. If you see a tumor and dilatation and duct is not dilated, it means that this would not be ductal adenocarcinoma, it would be some other malignancy. In pancreatic ductal adenocarcinoma, there must be dilated duct and there must be double duct dilatation. Pancreatic duct would be dilated and CBD would be dilated. If you see these both ducts are dilated, you can straight away confidently say that this could be pancreatic ductal adenocarcinoma. As far as sizes are concerned, it may appear in different sizes, small, large, it may appear hypoechoic or heterogeneous in echogenicity. So far the mass regularity is concerned, it may appear smooth or it may appear round or with be irregular with having irregular wall. Calcifications are very rare. Intratumoral cystic degenerative changes are very rare. So how we will be able to appreciate all these on the images? These images has been placed for you to observe and to write effective report on. So let's start watching these images, and through these images we will be able to appreciate pancreatic ductal adenocarcinoma. It is a transverse imaging, and you can appreciate a well-defined hypoechoic pancreatic head mass, which is indicated by black arrow. You can appreciate a hypoechoic mass in the head region, which is identified by the black arrow on this image, resulting in obstruction of the common bile duct. So common bile duct is markedly dilated here. Distal to the CBD, you can see intrahepatic ductal dilatation is also visible, but on this image it's a hypoechoic mass which is present in the head region, and it's causing significant obstructions of the CBD, and CBD is dilated. It's another example of pancreatic mass involving the tail region. As I mentioned that only 20 to 30% tail region is involved in periampullary cancers. On this transverse image, a hypoechoic mass is seen obscuring and replacing the entire tail region. Mass cannot be easily identified. At first look, it will look an anisotrophy, but if you look carefully and compare it with the size and echogenicity of the body and head region of pancreas, you will be able to identify this hypoechoic mass. Tail region is dilated and it appears hypoechoic due to the mass effect. So far the body and head region is concerned, both are normal in size and in echogenicity. This slide is the example of diffuse cancer. This transverse sonogram shows diffuse pancreatic carcinoma. Less than 5% of all ductal adenocarcinomas are diffuse. In this slide, pancreas is enlarged and pancreatic cancer is spread diffusely. As you can see, it appears heterogeneous in this slide, and its parenchyma is not homogeneous. Normal pancreas parenchyma appears homogeneous, but in this slide, due to diffuse mass penetration, it is heterogeneous. On this image, a large hypoechoic solid mass can be seen in the pancreatic head region. Mass is well defined and annotated as M. CBD is seen clearly dilated. This head region mass, which is likely pancreatic ductal adenocarcinoma obstructing the CBD. You can see the mass, it appears hypoechoic, it is clearly defined. One can easily appreciate that if you focus on the CBD, whenever CBD is dilated, always look for the pancreatic region, always look for the neck of the gallbladder region to look for any of the enlarged masses or enlarged lymph node. But this is the classical example of pancreatic ductal adenocarcinoma involving the head region and causing the CBD dilatation. Poorly defined mass can be seen on this image, although it appears as hypoechoic but clearly not visible. White arrow is indicating mass. As this mass is in the head region, that's why obstructing the pancreatic duct. Pancreatic duct dilatation is clearly visible. Due to desmoplastic reaction of pancreatic ductal adenocarcinoma, there must be ductal dilatation. Pancreatic duct would definitely be dilated. If ductal dilatation is not present and mass is visible, this would be some other pancreatic tumors. As I mentioned, there are 4 types of pancreatic cancer. This may be ampullary cancer, or maybe duodenal cancer, or maybe something else, but it would not be pancreatic ductal adenocarcinoma. Pancreatic ductal adenocarcinoma will always dilate the duct. This is another example of desmoplastic reaction. White arrow indicates small size, hypoechoic, well-defined mass in the head region, which is causing CBD and pancreatic ductal dilatation. This is called as double duct dilatation sign. So must focus on the pancreatic duct while scanning pancreas. As I mentioned earlier, that in pancreatic ductal dilatation there will be double duct dilated sign. So this is what double duct dilated sign is. Carefully look for the head region and try to appreciate any subtle findings or any changes in the echogenicity of the head of the pancreas. Heterogeneous, mainly echogenic pancreatic carcinoma. This transverse sonogram shows a tumor obstructing the extrahepatic bile duct. Increased echogenicity, white arrow shows increased echogenicity is unusual in pancreatic ductal adenocarcinoma, but anyhow you may come across with echogenic tumor as well. This heterogeneous cancer causes a double duct sign with pancreatic duct dilatation. PD is suggestive of pancreatic duct. The intrahepatic duct dilatation is manifest as dilated minor ducts, which is shown by the yellow arrow. So this is a rare form of the echogenicity of the pancreatic cancer. So this is mainly an echogenic pancreatic carcinoma. This slide showing obstructive pseudocyst caused by pancreatic ductal adenocarcinoma. On this image, you can see a subtle cancer in the body of the pancreas, which is indicated by the yellow arrow. With the pseudocyst formation, you can see this white arrow. White arrow is indicating pseudocyst formation distal to the mass, distal to the cancer. It is in the tail region, it seems. Mass is in the body region, while pseudocyst formation is slightly away from the pancreatic mass. Pancreatic head is not enlarged. Body appear heterogeneous due to ill-defined mass effect. Yellow arrow indicating the mass. Mass is ill-defined, it's not clearly visible. If you pay attention, you can pick the changes in the body region that would be due to the mass. While secondary pseudocyst can easily be seen, that is in the tail region, and it is distal to the mass. On this CT image, these findings can easily be picked. If you look to the body of the pancreas, a hypodense mass can be seen, indicated by the white arrow, and beside this there is a pseudocyst formation, which is again indicated by the white arrow. A well-defined round cyst can be easily picked on the CT scan images. So this is ductal adenocarcinoma and obstructive pseudocyst. For the detection of the pancreatic cancer, color Doppler ultrasound should be used to screen patient for resectability of pancreatic cancer. It is very important that you should look for whether the pancreatic cancer can be resected or not. Multi-detector CT scan and other examination can be used in patient when there is no sufficient evidence of the sonographic findings. Therefore, always put Doppler signals on, because Doppler signal during the examination, while there is pancreatic mass is present, it will help to identify whether this mass can be resectable or not. This slide shows very useful information. Look at this pancreatic color Doppler score. It scores from 0 to 5. 0 is the score when tumor does not touch a vessel, while a 5 score, in 5th score you can see that a vessel is totally obscure and totally included. So far, findings that suggest unresectability for cure, it include if the tumor is more than 2 cm, or if there is extracapsular extension, or there is vascular invasion, which we have discussed on the Doppler this scoring system, if there is enlarged lymph node around, and if there is metastatic disease. So these are the criteria when the tumor would not be able to resect. So therefore these are the unresectability criteria. Color Doppler sonography to evaluate the relation of the tumor mass is critical, and these critical vessels include portal vein, SMV, splenic vein, left renal vein, and IVC. These are 4 veins. You have to look for all these around the tumor, how much each of them is included. So far the arteries are concerned, arteries evaluated include the aorta. You must correlate the aorta with the extent of the tumor, celiac axis, splenic and common hepatic arteries, and superior mesenteric artery. Vessels that are touched or occluded by tumor are categorized according to a pancreatic Doppler score, which we have discussed. That score is really very helpful. You always take into account this scoring system. Other factors affecting resectability are metastasis, if there is distant mets. So again there is no need for the resectability, and if there is enlarged lymph node and this is metastatized in the lymph nodes, so therefore the tumor would not be resectable. Color Doppler sonography can correctly predict unresectability in 80% or more of pancreatic cancer patients. Here on this slide you can appreciate hypoechoic mass, which is indicated by the white arrow. This white arrow indicating hypoechoic mass, which is surrounding and encasing the celiac axis, surrounding the aorta. So this is a very helpful sign to indicate whether this tumor is resectable or not. In this case, as it is surrounding the celiac axis and aorta, this tumor is not resectable. Here on this image of the CT scan you can see that mass is encasing vessels, and this mass is again not resectable. Pancreas is visible, but the mass which is encasing, if you could concentrate on, so these vessels are occluded by the mass. So this slide shows that this mass is not resectable. Here on this slide on the right side you can see hypoechoic mass, a large mass, and SMV arrow indicating superior mesenteric artery, and on the right side again there is a large mass. So this mass is encasing the superior mesenteric artery. So whenever there is encasement of the vasculature, so then this is on the basis of the criteria, this mass would not be able to resect properly. So this is unresectable mass. On this image here you can see Doppler image slide which shows flow within the vessel. White arrow shows subtle mass which encasing the vessel. This white arrow around the vessel you can appreciate a hypoechoic mass lesion. This is subtle mass, cannot be easily identified, but if you put the Doppler flow within the vessel, so vessel will show surrounding hypoechoic area which is actually a mass. Again this is a unresectable mass because it is completely encasing the vessel, and on Doppler scoring it score 5, and in this case this mass is not resectable. This is resectability criteria by Dutch Pancreatic Cancer Group, and on the grounds of this criteria you can detect whether the tumor is resectable or it is borderline or it is irresectable. So far the arteries are concerned, common celiac arteries, superior mesenteric arteries, and common hepatic artery. If there is no contact, it means it's resectable. If it is less than 90% contact, it is borderline, and if it is more than 90%, so then the tumor is not resectable. So far the veins are concerned, if superior mesenteric vein and portal vein having less than 90% in contact with the tumor, so this tumor would be resectable. And if it is a 90 to 70 degree in contact with the tumor, so it means it's not no inclusion. Like we cannot say whether some of the people will consider it a borderline and some will go for the resectability, some will not go for the resectability. But so far more than 270 degree or greater than that, so then it would be irresectable. You won't be able to resect that mass. So this is again very helpful criteria. On the grounds of Dutch pancreatic cancer group, you can detect whether this cancer or this tumor of the pancreas is resectable or not. So it is mainly for the ampullary pancreatic tumors, malignant tumor. So we have discussed the color Doppler scoring, and we have discussed the Dutch pancreatic cancer group scoring. Hope this would be a very useful slide for the information. Yes, friend, this was all about pancreatic ductal adenocarcinoma. I do hope that you would be able to appreciate this pancreatic cancer on the imaging very confidently now, because there are certain important signs which I have discussed there, and you must be observing all these points on the imaging while you are scanning pancreas region. Must scan all these three areas: head region, body region, and tail region. Carefully analyze, make sure that your equipment is very sophisticated, because if the equipment is not sophisticated and the patient positioning is not okay, and you have not seen all these cases regularly, so there is a chance that you will miss this important disease, this important cancer, and in other words, I would say you might put the patient life at risk. So therefore, cautious, you must be very cautious while scanning the pancreatic region. If you are not sure, you must advise CT scan, that the patient should have the CT scan. Do not comment on the things which you have not seen. Do not comment on the pancreas which is not available, which is not visible to you on the ultrasonography. Most of the time we have seen that there are already ready-made format, and we just pass on this directly to our colleagues, that pancreas is normal, and head is normal, and tail is normal. This is not a good practice. Try to see all the components of the pancreas. If you can see the head region, confidently mention that head region is visible, body and tail is obscured by the bowel gases. If it is unable to visualize, just mention that pancreas is obscured by the bowel gases, or pancreas is unable to visualize on the scanning due to high BMI. So there are certain limitations. I'm sure that our other colleagues, surgical colleagues, medical colleagues, and other related colleagues, they are well aware of the limitations of the ultrasonography as well. So if you feel and if you are confident, then mention about the pancreas confidently on the report. And if you think that you have not seen properly the pancreas region, so mention on your report that further radiological modality should be considered. So I do hope that all these important imaging which you have seen, so it will help your to enhance your academic knowledge, your practical knowledge and practical skill. So please keep sending me your updates, because due to your update I realize that something is missing, or I have to discuss some other points, and I can update all these videos. So hopefully we'll be able to see in next video with some other important topic. Till that, take great care of yourself and keep watching my video. We'll see you in the next video. Till then, bye bye.